Thank you very much, Dr. Lapidot, for the presentation and for the invitation to this Congress. Today we are speaking about the contribution of the laser in the treatment of the venous malformation in relation to a clinical case. As we know, the venous malformation has an incidence of 4 in 10,000 births that appears by an activation of the PI3K and AKT and mTOR pathway that leads to an enlargement vessels and sometimes consumption, coagulopathy, and obstruction of vital structures. The diagnosis is made with a clinical manifestation. We see blue lesions with a progressive swelling that usually are compressible and soft, except when we have phlebolites with no trill and not warm. It can be painful, particularly post-exercise, and may involve the skin, the mucus, or any other organ. The diagnosis is done with clinical manifestation, but it's supported by the alteration of the blood test, the dimer and fibrinogen. The biopsy is useful when we are studying the genetic part of the lesion. We observe an enlarged vessel with endothelium composed of a layer of cells surrounded by irregularly smooth muscle cells. The X-rays show phlebolites involvement, and the ultrasounds confirm the slow flow malformation as a hypoechoic or heterogeneous lesion, and MRI is useful prior to the treatment or in uncertain diagnosis. There are different subtypes of venous malformation: sporadic, familial, unifocal, or multifocal. Today we're speaking about the unifocal sporadic venous malformation. For the management of this kind of lesion, we require a multidisciplinary unit to guide a personalized approach. In this team, we should incorporate the dermatologist, pediatric, vascular, and plastic surgeon, oncologist, pediatrician, radiologist, traumatologist, and other specialists like the ophthalmologist. The combination treatment include the compression garments, percutaneous sclerotherapy, surgery, drug therapy, laser, and other types of treatment like intralesional radiofrequency or cryoablation. As we know, in normal condition, angioprotein 1 binds to type 2 receptor, triggering the PI3K recruitment, activating the AKT and mTOR pathway, leading to endothelial cell proliferation. Venous malformation often results from activation of this pathway with 2 types of mutation measured in these cases: TIC mutation with 60% of them encoding the type 2 receptor, and PIK-CA mutation with 20% of them. And understanding these pathways enable target drug treatments. We have, for example, we have said before, sirolimus. Sirolimus is a treatment that 7 patients with venous malformation treated with sirolimus out of 19 with low flow malformation show good results. 3 patients need stop sirolimus, 2 cases with grade 3 mucositis, and 1 spontaneous not specified. The results show a 4 patients with partial physical and functional and pain improvement and increase of quality of life after 12 months. In another 10 case reports, median follow-up of 24 months, describe the effect of oral sirolimus for the treatment of venous malformation. The results show a reduction in the lesion observed in almost 90% of them. In a more recent study, showed that the volume of the venous malformation detected on MRI were not significantly different after the treatment with sirolimus. In conclusion, sirolimus has been tested in pediatric and adult venous malformation. The dosages are adjusted based on pharmacokinetics, and regular monitoring is needed to identify toxicities and maintain therapeutic levels. There are different side effects that we need to know them, and the outcomes show a decrease of the dimer levels, pain, coagulopathy improvement, and mild reduction of venous malformation sites. On the other hand, we have alpelisib. Alpelisib in vitro studies and in animal studies show superiority over sirolimus and control in the inhibition of this pathway in terms of cell proliferation. In this case series with 3 patients with venous malformation and type 2 receptor mutation received 6 months of alpelisib, pain gauge and coagulopathy improved, and venous network size decreased significantly. In conclusion, the experience with alpelisib today is minimal, and it's limited to in vitro experiment and small case series. The dosages are adjusted based on pharmacokinetics, and regular monitoring is needed to identify toxicities and maintain therapeutic levels. There are different side effects that we need to know them, and its application to patients with low flow malformation seems promising, and we think that it is the present and the future in combination with other treatments like laser, but requires further large prospective trials to confirm its safety and efficacy. Today in Barcelona, we are doing a large prospective trial in collaboration with other hospitals around the world. We report a case. Alejandro is a 16-year-old male patient with a unifocal venous malformation affecting lips, tongue, and cheeks with no family history. He had spontaneous bleeding, difficult in eating, speaking, and sleeping, and he showed no pain. He had not received previous treatment before. The MRI showed that the venous malformation extended to the subcutaneous tissue, facial muscles, and the planes of the floor of the mouth. The angiography confirmed the slow flow malformation as a venous malformation. And in our case, we chose at first moment the percutaneous sclerotherapy. But after the sclerotherapy, Alejandro had a post-sclerotherapy bleeding after a trauma requiring ICU admission. In invasive approach, it's necessary to remember that we need to give rapamycin or heparin before and after the treatments. For further sclerotherapy session, in this case, were discarded. In this case, we choose the laser therapy because we know that laser therapy could be our first option in most of patients when in combination with other treatments in vascular and vascular malformation and tumors, when the complete excision is impossible, the anatomy represents a surgical obstacle, and the preservation of the vital anesthetic structures is difficult, and has special value in venous malformation with panfacial localization, extensive area like trunk or extremities. Alejandro has 3 of these laser indications. There are different lasers used to treat the venous malformation. Transcutaneous laser with cooling system is used in different sites of lesions. We have transcutaneous coagulation with absence of external scars, the possibility of local anesthesia with an outpatient surgery, the reduction of surgical risk with better postoperative recovery, and with good aesthetic results. For example, the 918 nanometer diode laser is used in nodular lesion with good results in this mucosal area. We have we use usually in our hospital the transcutaneous neodymium YAG laser has shown that with cooled sapphire crystal, it's used in nodular and superficial lesions show good results. Also in the extensive area like face or extremity with safe profile. All these kind of lasers, transcutaneous lasers, can be combinable with other techniques like surgery or sclerosis. In another hand, we have an intralesional laser. We do an incision and 2 centimeters of the lesion. The laser fiber contacts directly with the oxyhemoglobin. The refraction and reflection are in situ, and we have a direct coagulation at different depths, advancing and retreating the fiber. Intralesional laser is a treatment of choice in extensive and deep lesion. We have a bloodless field with good aesthetic results. It's very important to remember to control the heat-related side effect to avoiding healthy tissue necrosis, tearing, and gas embolization. The international neodymium YAG laser is what we are using in our clinic. It's safe and minimal invasive and could become a first-line treatment modality for extensive venous malformation. In another hand, we have the 1417 nanometer diode laser. This laser we have acquired for 1 month in our hospital, has shown a reduction in vascular side symptoms and the dimer. It's safe and minimal invasive, and we have no dose, session, or toxicity limitation, and may be combined with other techniques. There are different techniques that we can combine with the laser, like the bleomycin in this paper show that it's a safe combination with no lesion, rupture, or bleeding, with symptoms improvement in 7 out of 8 patients. Another typical combination is the treatment with the endovascular laser with sclerotherapy, with ultrasounds. That shows that it's a safe, safe for persistent bulky intramuscular lesions. The combination of direct thermal damage with chemical sclerotherapy is the strength of this approach. There are coming novel and promising therapies. Today, experimental treatments try to optimize the thrombus formation by combining conventional laser therapy with thermosensitive, prothrombotic, and antifibrinolytic drugs. The goal is the complete luminal occlusion of target vessel and could serve as an adjuvant treatment for other types of vascular malformation, like the capillary malformation with the pulsar laser. We show you a successful example of laser therapy done in our hospital, in our clinic. The laser can be the first treatment option in vascular malformation and tumors when the complete excision is impossible or the anatomy represents a surgical obstacle. Also, or the preservation of vital anesthetic structures are difficult or dangerous, and has special value in venous malformation with a panfacial localization, or in other areas like the mucosal area where other techniques are not possible to remove completely the lesion, like the surgery. Also, we see after the laser treatment a recovery of the soft parts. It's typical that we see, and also the recovery of the muscle tone after the laser treatments. We have good results also in lesions when other treatments were done before, and also in extensive area like trunk or extremities. In deep and complex lesion, endovascular laser is the first option. In Alejandro, we choose the laser therapy as this option for doing for him. And Alejandro, we done 7 sessions with an immediate reduction of the lesion sites with a favorable postoperative period without complication, an absence of bleeding, improvement in speaking, eating, and sleeping, and the patient satisfaction achieved after 4 years of follow-up. This is the exact moment after the first laser treatment in the operation room. We see the coagulation of the lesion and the induration that we have after the treatment, not only in the mucosal area, we can treat all the part of the lesion. This is the most important thing about the laser treatment, that we can treat in the same moment all the lesion that we can't do with other treatments. After the treatment, Alejandro has shown a dramatical response without symptomatology in this moment. And in our case, we don't use plastic and reconstructive surgery, but sometimes it will be necessary for recovering the soft parts. Also, the lesions of the mucosal area has reduced completely and without recurrence after 4 years of follow-up. In conclusion, we think that laser therapy should be considered as must-have therapy in the treatment of the venous malformation. Several laser approaches have been proposed, transcutaneous, endovascular, and combination with sclerotherapy or drugs. We used the transcutaneous neodymium YAG laser in our patient Alejandro with an excellent outcome after 7 sessions. And the pharmacological management today has an important role, and it will be a must also, and combine it with other techniques like laser. Compared to more invasive approach, laser therapy generally offers a better safe profile. A multidisciplinary team is required for an accurate diagnosis, tailored treatment strategies, and optimal patient care in venous malformation and also the vascular complex vascular malformation and tumors. I invite you to come to our hospital to see us and discuss different types of treatments for different patients, or be connected with you when you want. And I'm able to respond to your questions, or if any one of us want the presentation, I will give you. Thank you very much.
Thank you.